Good afternoon, everyone, and welcome to today's webinar hosted by the American Academy of Pediatrics and HealthyChildren.org. Today, we'll discuss asthma symptoms, common triggers, tests and treatments, and how you can keep track of your child's symptoms with our new AAP Asthma Action Tracker. Before we begin, a few housekeeping items. This webinar is being recorded. If for some reason you lose your connection or need to drop off, you can find the archived version on our website in a few days. If you have technical issues during the webinar, go ahead and use the chat function to send us a message. We will have time at the end for questions, so please feel free to send them at any time through the chat, and then we'll get to as many as we can today. Now, let me introduce Dr. Jennifer Shu. Dr. Shu is a practicing pediatrician, author, and mom in Atlanta. She is a frequent guest on national and local TV, radio, and web-based programs, and co-author of the AAP books, Heading Home with Your Newborn and Food Fights. Dr. Shu is also the medical editor of HealthyChildren.org, and of course, we're the official parenting website of the AAP. Welcome, Dr. Shu.
Thanks so much for having us today. We're just coming off the end of the winter respiratory virus season and starting the spring allergy season. And both of these things can trigger children's asthma. So joining us today to talk about asthma is Dr. Clint Dunn. He is a board-certified pediatrician, an allergist, and immunologist who practices in the Hampton Roads, Virginia area. As part of the Children's Specialty Group, Dr. Dunn sees patients at Children's Hospital of the King's Daughters as well. Dr. Dunn is a member of the American Academy of Pediatrics and the AAP section on allergy and immunology. His clinical interests focus on atopic dermatitis, asthma, food allergy, and applying high-quality evidence-based medicine for the improvement of pediatric allergic and immunologic diseases. Welcome, Dr. Dunn.
Thank you so much for having me. This is an awesome topic, and I'm super excited to talk about all of it with everybody.
Great. So we'll just start with the basics. If we can get the first slide, we're going to talk about asthma and how common is it in children?
Yeah, so this is something that I love working with families, with our young patients and our adolescents and talking about, because it's one of the most common chronic lung diseases that we see in the United States. And when we say chronic, we mean that it's long-term, and it's not something that you can look at somebody and say, oh, they've got asthma, oh, they got asthma. Unless they're having a flare-up, they may be walking around looking normal on the outside, but they can actually have problems, and it can affect 1 in 10 kids in the whole country, but in some communities, it's as high as 1 in 4, which is something that we really need to try to focus in on a lot more. It's one of the most common causes for kids for missing school, so it can affect education and it can affect children's hospitalizations. And so it's an amazing thing that we want to make sure that we kind of break it down. And asthma has 2 phases. So what we know when we describe asthma is there's the symptoms that we see. So whenever we talk about it, there's cough, wheezing, shortness of breath, chest tightness. It can affect their ability to play and exercise or when they're sick. But whenever we actually look at it, we always focus on those, and underlying it is airway inflammation that kind of tips over that scale. So it's kind of like a simmering pot that's causing it. And that's one of the ways that we try to combat it when we talk about treatment. When we talk about our asthma flares, they're serious. They affect their breathing. They can make kids have to go to the pediatrician or to the urgent cares or the hospitals or the ERs so they can actually do it, because there's ongoing airway inflammation that's closing down the airways, and that they have to need more treatment or medicine specifically to help them whenever we actually have problems.
So what are some of the ways that you might be able to tell how severe a child's asthma is?
So one of the best things is having long-term care, right? So I can't preach enough, not just as an asthma specialist, because there's not enough asthma specialists in the world, but really having a great relationship with our community providers. So Dr. Shu, as a pediatrician, we lean on all of them. We lean on everybody. And the biggest thing that we do when we're taking care of anything is, if we're doing our job right, we're asking questions. We're asking, how often is it bothering them? How often are they coughing? How often are they wheezing? How often is it waking them up at night, right? Not letting them get good sleep, or is it keeping them out of school? How often are they needing extra medicines, or how often are they using their medicines? And especially to get that initial diagnosis, some of the risk stratification, so the family members and everything that they can actually see as we go about, that kind of helps risk stratify why it happens in each individual.
And there's some tests that can be done to look at
Yeah.
asthma severity.
So whenever we talk about asthma severity, I always think about them like vital signs for the lungs, right? So every single time somebody goes into a healthcare setting, we've all seen it, right? We've gotten, I have two kids, and so they get, their height, their weight, they get their vital signs, right? Their heart rate, their respiratory rate, everything like that. We have things like that. There are vital signs for the lungs. Some can be done really simple in all of our community primary care doctor offices. And some of them are a little bit more specialized. So one thing that can be done at home is these things called peak flow meters, which are kind of real live time things that they can take home. And so they can actually have on a regular basis to give us real feedback. And then when they check in with their pediatricians or with their asthma specialists, we can do specialized testing, like what's called spirometry testing, where they take a big deep breath in and we have to punch air out of their lungs so we can actually help them see what our lungs look like in real time. And then some other specialized testing that I like to use are measures for airway inflammation. It's also called the exhaled nitric oxide. When there's questions about, is this asthma? Is this not asthma? We'll do some other specialized testing for provocation or causing us to have symptoms or determining if our airway is having problems, like methacholine or allergy testing or looking at the lungs with imaging. So there's a lot of different ways for us to look at the lungs.
Let's talk a little bit more about the common asthma triggers, such as some virus infections and allergens, and anything else you'd like to mention.
So the way that I kind of always like to break them down for my patients is what is outside going to affect us, and then what our immune system is going to interact with. And so in pediatrics, so in kids that have asthma, the number one, number two, number three most common triggers are going to be viral infections. And so that's why we kind of are coming out, like you had said, out of viral season. It's a big important time for us to think about it. And it's why, we've really put an emphasis on hygiene, on washing hands, making sure that we don't spread it to other people who are vulnerable or at risk whenever we are sick. And there's certain infections that tend to affect the lungs of young kids a little bit more. So whenever we're much younger, the babies, we see RSV being something, but rhinoenterovirus, influenza, adenovirus, there's a lot of viruses that can affect the lungs and can kind of cause us to have those symptoms. So making sure that when we're sick, we're trying to stay home so we don't get other people sick, and making sure that we're washing our hands, especially our young kids. And then other things in our environment, right? Tobacco smoke, strong odors, vaping, e-cigarettes. The caregivers really can have an impact on the lungs and what we actually see. We know that in urban settings, a lot of the air pollution and the smog that we see around things affects the lungs, and it can actually we actually know that we can run into more problems. And so thankfully, a lot of our weather apps, right, whenever we open up our phones, can give us the air quality index. And it helps tell us when some kids should stay inside or when some people should stay inside, so that we can kind of know when's the right time. And then certain strong fragrances, like some of our bleach cleaners, can actually cause problems. So using some of the more softer fragrance products is something. But one of the biggest things that I focus on as an asthma specialist, but also as an allergist immunologist, is really things in our environment, things like indoor and outdoor allergens, with our year-round allergens being one of the most common causes. And we focus on seasonal, right? Just like you said, we're seeing our seasonality, our tree pollen in most areas. Indoor allergens are one of the most common smoldering year-round things that can affect our lungs. So dust mites, which are not visible dust, this isn't reflections of hygiene or cleanliness. It's reflections of being human. Dust mites live with us. They live around us. They live connected with us. And then cockroaches and animals. You're going to get rid of us as healthcare professionals more often than you're going to get rid of our pets. But making sure that we're aware of what can cause problems with our patients or children's airways. For dust mites, they do make dust mite covers, which you can get at most major retailers, and then making sure that we're doing all the simple things, right? Practicing good cleaning and washing. For outdoor allergens, you can't make a kid not be a kid, right? So it's all about how do we live our life in our environment? How do we make sure that we're set up for success? But knowing that a lot of our tree, grass, and weed pollen, it's like Velcro, it sticks to us. And so trying to make sure that we minimize what comes back inside passively whenever we're there or not there, and then actively whenever we go out. And so kind of knowing what time of year we need to be most attentive to, washing off, and then, letting our kids be able to go outside, making sure that we're prioritizing when it is safe that they can. Exercise is a hard one. So, we have a tendency to, I don't want to say penalize people when they actually have to use their inhalers, but we kind of run in the face of what we always say. As a pediatrician, we talk about how often you should play, how important it is for health and wellness, for cardiovascular health, and pulmonary health for exercise. And if people have problems with exercise, I'd rather them use their inhalers beforehand. And actually don't consider that a use, because it's one of the best things that we can do, is make sure that our kids are able to play. And so if they have to use it, using it before so they don't run into problems and it limits them.
Great. Let's move on to the next slide. What about treatment for asthma?
Great. So because it is a chronic disease, because it's a chronic process, it's not something that you can just use once and then walk away from. So there's a lot of different ways that we can get the medicines into our lungs. And because it is our lungs, we have the ability to do inhaled products. And so there's a couple of different inhaled products. Most of us have seen, if you have had to go to the emergency department or urgent cares, you've seen nebulizers, which is when they take a liquid medicine that can be aerosolized so that it can be breathed in. That's what a lot of times we use for urgent settings, because it can be tied with oxygen so we don't lose oxygen. A lot of it ends up being swallowed, and equally effective are some of the inhaled products. Actually, sometimes we get more medicine into our lungs when we use the inhaled products rather than having to use a nebulizer. Nebulizers make you sit down. They make children stay calm, which can be hard in some of our kids. And so some of our inhalers, sometimes they're called puffers, sometimes they're called meter dose inhalers. They're the ones that we classically think of with a button. Because they propel so fast, using a spacer actually helps make more of the medicine get in there. But then there's what are called our dry powder or disc devices that are breath actuated. And then there's also some pills that block some of the inflammatory pathways that can cause problems with asthma. We started to move for our moderate to severe asthmatics to what are called injectable medicines. So if you look at a lot of our asthma guidelines, if I ever reference our asthma guidelines shorthand, I apologize. The two major asthma guidelines are the Global Initiative for Asthma and the National Heart, Lung, Blood Initiative for asthma. And so both of them have different kind of perspectives, but for our more severe asthmatics, treating the underlying allergy or treating some of the underlying inflammation with injectables, those are called biologics, is sometimes what we'll talk about. They come in different names, they have different functions, but some of them are like dupilumab or Dupixent, omalizumab or Xolair. There's Nucala and Fasenra. There's a lot of different things. We kind of break down controller medicines, or things that decrease symptoms on a regular basis, and then fast acting. And so the fast acting ones are the ones that most people are probably most aware of. That's classically albuterol. It's the most commonly used one. We're starting to move towards a newer, kind of a newer mentality, which is something called formoterol. It's albuterol's sister, and it just is tied into an inhaled corticosteroid to calm down inflammation. And so probably one of the most common chronic medicines that we use are daily medicines, trying to set us up for success, because this is an inflammatory condition. So it's not something that I can just take away like that. You got to treat it. You got to put it on like suits of armor or like body armor around the lungs to build up a layer of protection. And so whenever you actually look at some of the treatments, it's for kids that are needing medicines more often, or if we know if they're getting sick or they are sick, to kind of help treat those aspects. And so the most common one we use are the inhaled corticosteroids. Some of them are like fluticasone, which is Flovent, or beclomethasone, which is Qvar, and some of the other ones can be combined with medicines. So those are called our combination medicines, or inhaled corticosteroids, long-acting albuterol-like medicines, and that's like Advair or Symbicort or Dulera. The pills that we typically use are called like Montelukast or Singulair, and then I did kind of already talk about some of the biologic options.
Okay, so now that we've talked about the treatment, how can you tell if a child's asthma is under control?
So I love seeing how much it's interacting and interfering with them. Probably the biggest thing is their perception, each person's perception of how are they defined by their asthma, or are they not? So how much are they coughing? How much are they wheezing? How much are they waking up? How much medicine are they actually needing? Are they having to have extra medicines? How many times are they having to go to for acute care, right? How many times are they needing oral steroids? Because we know that oral steroids over life are something we want to use judiciously. We want to use them appropriately and not be entirely reliant upon them. And then how much are kids able to be active? I think that we try to break it down into how much it's interacting with us, and how much our asthma is interacting with us, and how much it's stopping us from being able to function.
Okay, and can you tell us a little bit about an asthma action plan?
So this is something that is in all of the major asthma guidelines. And so it is something that every individual with wheezing, with a medication prescribed for their lungs, should have written down to spell out to the caregivers, all the caregivers, including schools, so that they can know what to do. And it's really nice because it's based off of the streetlights, which is something that we've commonly seen. And so we break it down into when things are good, that's our green zone. We're doing great. Those are our, if we need controller medicines, if we're on a daily medicine, that's when we should be taking them. We should spell out when do we take them. And then yellow's kind of like our warning zone. It's our, we're not normal. We're coughing, but we're not working harder to breathe. We're able to get better. And that's when we kind of try to start getting on top of it. So we don't go backwards. And then the red zone is stop, right? Everyone should be pausing. We should be making sure that we are, making sure that we're stopping and treating what we're doing. And that may mean we have to go to the emergency department, or we go to the urgent care, go to our primary care doctors, because I think that it's important. And it really should be something that's discussed with our providers, whether that's our primary care doctor or asthma specialist, so that we can make sure that it is tailored to that individual.
So that's something that a doctor might give to a patient, and then the patient can share it with a school or childcare, et cetera, right? Okay.
Absolutely.
And then there is a web-based tool from the AAP. Can you tell us a little bit about this Asthma Action Tracker?
So this is an amazing initiative that really the American Academy of Pediatrics has been spearheading and working alongside to kind of take control of people's breathing. It is a web-based kind of tool, or kind of like an application, which helps give us, as the providers that are helping to take care of the individual, how often are they running into problems? And then it helps actually clarify some people's triggers. Sometimes what we think are our triggers end up not necessarily always being our triggers. And so it gives a daily check-in where you have a short time as the caregiver where you can say, hey, how is my son or daughter's or my child's breathing doing? Are we good? Are we not good? And then it tells us how many days we're not good, so that whenever we go in and check in with our normal asthma check-ins with our providers, is that we don't have to sit there being thinking like, oh, have we had issues with our breathing? It's like, hey, I can flip it around. I can show you we've had this many days in green, this many days in yellow. And it really is an easy way for us to kind of follow over time when they've needed medicine and when not. And actually can put in what medicines we should be using at each step.
Excellent. I'm not sure if other people have lost these slide images, but I'm not seeing them anymore. Might just be me, but we are moving on to the question and answer portion anyway. So there really aren't any important slides left. So thank you for everybody who has submitted questions either ahead of time or in this chat group. Our first question from our participant is going to be, are nebulizers more effective than inhalers?
I think it's a question that we get asked all the time. And so I don't think that it's a question of which is more effective. I think that they each have different uses. Nebulizers are nice because they make people sit down. They make people stay calm. They have the ability in healthcare settings to be attached to oxygen. And so they have the ability to be like that. Now, actually, a lot more of the medicine ends up getting swallowed because it's a continuous nebulization, a kind of breaking down the medicine as liquid droplets into smaller droplets that can be inhaled. So a lot of it actually does end up getting swallowed into the lungs. And so you're actually getting not as much medicine. The modern inhalers, if you take a modern inhaler, which is kind of the what are called meter dose inhalers or a puffer, and you put it directly in your mouth, in known asthmatics that are adults that are over the age of 20 with perfect technique, the modern propellant only gets, it's so fast, only about 21 to 22% of the medicine actually ends up in our lungs. But whenever you do a spacer, you can actually get greater than 85 to 90%, which is more than the nebulizers as well into the lungs. And so I would say that it depends on the child. I think that whenever we talk about it, we've all seen the child that's dinging around the room and you can't catch them and you can't hold them down. And the concept of having them sit there for 15 minutes to do a nebulized treatment is just it's not gonna work. It's not gonna work. And those ones, in those individuals, it may not be best to have a nebulizer. But for some people, it's the spacer, the coordinated breath, holding on the face mask is more anxiety provoking. And so it's harder for them to do the concept of a face mask with a nebula or with an inhaler. And so it's just different.
Hmm. So maybe as a child gets older, I've heard that if they stop using the spacer, they may actually need to do more puffs than if they had been using the spacer. Does that sound about right?
So a lot of we have some standardized ways of dosing it, but really there are some flexibility into it. So there's been a lot of good looking into our asthma care, and it's published in our asthma guidelines, where sometimes we have a tendency just to be like 2 puffs, right? 2 puffs, 2 puffs. But some people need more because it's we've all seen the 350-pound linebacker that has asthma, and they probably need more puffs than an itty bitty baby. And so it needs to be tailored and adjusted. Yeah.
Okay. Our next set of questions is about controller treatment, mostly about inhaled steroids. Are there any side effects or concerns we need to know about, such as can they cause thrush, which is a yeast infection in the mouth? Can they impact the teeth somehow? And do they have any kind of effect on your height growth or weight gain, for example?
Great question. So the easy answer is anytime something sits in the mouth, it can affect the good bacteria, the mix of good bacteria and bad bacteria, the mix of good organisms and bad organisms in the mouth. And so after you use any of your controller therapies that you have in an inhaled corticosteroid, you should rinse out your mouth or brush your teeth. And that also helps build in the habit of taking it on a regular basis. So if you put it right next to your toothbrush, hopefully our children are remembering to brush their teeth at least once a day, hopefully twice a day. And so it's really important for us to just make sure that we don't have anything sit there on the mouth or on the teeth, because it does increase the risk for dental cavities or caries, and it can increase the risk for thrush. The height question is something that we struggle with a lot. So whenever we look at it over a long term, the difference between an inhaled steroid and an oral steroid is very, very different, right? An oral steroid is sometimes equivalent to using a daily inhaled steroid for up to a year. And so we have a tendency to go really quickly to oral steroids for exacerbations or flare-ups of our breathing. When you look at the literature for inhaled steroids, there were some of the literature early on that showed that individuals that were on inhaled steroids that were pretty high dose for over a long period of time, they may have had a slight lower growth velocity. And I'm cautious on saying that because it didn't really affect their end height. It just may meant that they were in the NBA or the WNBA playing power forward instead of center. And so it just may have taken them a little bit of extra time. But it's hard. You have to weigh into the fact that if you can't breathe, can't grow. And so trying to find that balance is something that you really need to work on with your individual provider to find what's the best therapy for the individual.
Okay, great. Thank you. Let's talk about at what age can a child begin using something like a peak flow meter where you can test how their lungs are functioning maybe at home?
Great question. So we typically start, the earlier you can start, it's a learned skill. And so it takes some time to kind of fully master that. Sometimes we'll start at 5 years old. And so it starts them learning how to do it. Now, the validity and the accuracy of a 5-year-old compared to an 18-year-old is different. And so peak flows are a little bit easier. They kind of look like a big, like a harmonica that's turned sideways, is kind of how I would conceptualize it or kind of picture it in your mind. And it gives you the ability to track what's their best. And there are calculators that we can use for body weight and how to calculate what their max should be. But usually we start trying that around 5, and then we definitely really start trying to push pulmonary function testing to get real live quick data on the vital signs for the lungs whenever they get to be around 6 to 7.
Thank you. Let's talk a little bit about rescue inhalers. We had a couple questions about that. So for somebody who's maybe using their rescue inhaler very often and is considered not well controlled, what do you do in that situation? They're maybe using it several times a day and may not be on a daily controller.
So whenever we look at the rescue inhalers, the reliever inhalers, it's hard because we've trained generations that albuterol is my asthma treatment, and so grandparents, that's what they taught their kids, which has been passed down, and so Albuterol alone as our only therapy is starting to fall out of favor because it only helps open up the muscles of the airways. So remember when we talked about asthma is an inflammatory condition. Albuterol relaxes the muscles. It starts working in 3 to 5 minutes and it lasts for 3 to 4 hours. But it doesn't fix what's going on inside the lungs. It helps open them up, but it doesn't fix it. And so whenever we look at it, a lot of our newer asthma guidelines are starting to move towards that emphasis on inflammation. And so that's kind of how our progression of asthma has gone. Where it started out as we just focused on the acute, and then or kind of those flare ups, and then we started to be like, oh, how much is it affecting us on a daily basis? And now we're starting to move towards, okay, so what's underlying it? And so albuterol doesn't fix that underlying. And so I would say if we're needing it outside of exercise, if we're needing it more than 2 times a week, we as the healthcare professionals probably need to be talking about how we can do a better job to take care of somebody's lungs.
Excellent, thanks. Let's talk about if a child has asthma, or let's talk about if a child has symptoms of asthma, such as wheezing at age 1 or 2, can we diagnose them with asthma? Or if they have a cold and have wheezing at age 1 or 2, what are their chances of developing, official asthma in the future?
So this is a good question because I'm always so sitting up in my ivory tower as an asthma specialist. I'm going to turn back a little bit to you, Dr. Shu, because as a pediatrician, how many times have we heard the polite term, which is reactive airway disease?
Yeah, all the time, right?
And so sometimes we as pediatricians have a tendency to be very polite. And that's a good thing. I think we should be polite. I don't think we should be mean, but I do think that we should call a spade a spade. We should say things when they are. And so if you look at your asthma guidelines, they say that you should never manage asthma without taking lung function testing and following them over time if they're not responding to therapy. But in our young kids, in both of our asthma guidelines, they actually have designated clinical criteria, and they break it down and they say, hey, let's risk stratify them. And so there's multiple different scores. There's one called the Asthma Predictive Index. They talk about the Pediatric Asthma Risk Score. And I like using those to help predict which kids need to be intervened on sooner. And so whenever we talk about it, I give you a pass once or twice, right? If you've had 1 or 2 times, similar like if you've had one flare in a year, I don't want to overreact for one thing. But asthma, if you look at your asthma guidelines, is symptoms of cough or wheeze or shortness of breath that has occurred on 3 or more occasions and responds to either an inhaled medicine like albuterol or an oral steroid. And so we have a tendency to be too polite. And I think that what we're going to see is the individuals where we intervene on sooner and we start considering should we call them asthma and start therapy sooner are actually going to do better in the long term. And so I talk through that with the kids that I see, the patients and the families that I see, and I give them choices. And I think that sometimes we as healthcare professionals are a little bit too slow to consider should we be intervening sooner.
Okay, so 3 separate times with all those things that you mentioned. Excellent. Okay, so if a child is prone to things like allergies, eczema, and has wheezing, and you've called them a person with asthma, what are the chances they might outgrow it?
So outgrowth data is hard for us to always say because in studies, there's a huge separation. So absolutely, people outgrow their asthma often. The rates are a little bit harder for us to say. Some studies will say a third, some studies will say 50%. I think that it depends on the severity or the individual, and that's where you need to have kind of a relationship. You have to have somebody who follows it over time so that they can say, when things shift or when things change or whenever they're not needing things, so that we really should be considering de-escalation when things are good so that we can make sure that we don't over medicate our children while also not making sure that we're under medicating them.
Okay, great. Can you talk a little bit about kids who only have cough but might have asthma, so without wheezing?
Yes. So there's something that's unique about some children. So they can have something called cough variant asthma. So it's not the classic wheezing, shortness of breath, right? They're working harder. They cough. And Cough is a protective reflex for the lungs. So whenever we talk about cough, cough is there, and I don't want to ever take away cough, because cough is a protective reflex to make sure that nothing settles in the chest, that if there is something in the chest, that it clears it out. And so whenever we talk about cough, chronic cough or kind of longstanding cough can be hard for a lot of families because there's not always as clear cut of an answer. But young kids can have something called cough variant asthma, where they get better with asthma tailored therapy. And it's usually the cough comes in fits. So it's usually like certain things provoke their cough. So when they're running around, they're the kid that about halfway through playing with other kids, they're slowing down a little bit and they're starting to cough. And it's not just like it's like it's like back to back, and it's coughing in fits, or it's affecting them at night whenever they should be sleeping. That our natural body steroids that we all make from a part of our body called the adrenal glands goes down, and then we unmask sometimes where there is some underlying inflammation in the lungs that shows up as cough, and it's usually waking them up and causing them problems.
Thank you. You mentioned pets earlier. What if a child seems to be allergic to their family dog or cat? Do they need to get rid of the pet?
So as somebody who has pets myself, I always make the joke to parents whenever we do allergy testing that that if it tests positive, you're going to get rid of me before we get rid of our pets, because doctors that recommend to get rid of our pets get fired at a rate higher than any other doctor in medicine. And so I kind of like to make sure my patients don't fire me and that I get to help take care of them. And so it's all about living our life in our environment. And so if we know that pets bother us, usually you tolerate your pets better than other people's pets, but trying to keep the pets out of the area where the kids are our children are always at, right? Keeping them out of the area where they play, making sure we keep them out of the bedroom, which is something that we always kind of want to think about. The frequency with which we wash and groom our pets can actually decrease how much allergen sits on their coat and can actually get aerosolized. And the frequency with which we clean, right? The more we vacuum, HEPA filters can help with some dog allergens. And so trying to make sure that we find the balance of not taking away their fur friend, but also making sure that we don't provoke their asthma.
Okay, our next question is asthma hereditary? Does it run in families?
So there are risks for asthma running in families. There's certain individuals, certain populations that there are genes that are passed down. It's not always one-to-one. And by that, I mean, it's not always because mom and dad have it, my kids will have it. But it's all about what our exposures are. So our lungs are probably one of our biggest exposure areas in our body, other than maybe the skin, that we kind of see our world at. And so it's not always that parents are going to give their kids asthma, but there is a higher risk for it. And it's one of the things that are in our asthma risk scores that would say, hey, we probably should be considering it sooner.
You mentioned kind of being exposed to things which can impact the lungs, which are, a big part of our bodies, and also the skin. Do you ever see a relationship between asthma flares and eczema flares? And if you treat the asthma, will the eczema be treated too?
It's a good question. So we know that atopic or allergic conditions kind of run kind of like a domino, where they start as one and they kind of progress on. So there's something called the atopic march or the allergic march. And so by that I mean it's kind of like ants that march across the ground, and it kind of goes in order. With eczema being an early precursor, an early sign that somebody may have a more increased risk for allergic conditions. And we know that can be a risk factor. Specific to exacerbations, yes, some environmental factors can correlate with exacerbations of eczema and asthma. Treating the asthma exacerbation with oral steroids can help with a lot of allergic disease. The problem with saying, hey, I'm going to treat somebody's asthma and it's going to help with their eczema. Some of the biologic therapies can help with both. They're really indicated for multiple allergic diseases. Some of the short-term treatments for acute exacerbations can run into more problems, because some people with eczema, if we use oral steroids for their eczema can get better temporarily for a short time and then flare worse as they're coming off it. So it's always kind of a delicate balance.
Let's talk about when it's okay to stop controller medicine. So once you start the controller, because you're giving, let's say, an inhaled steroid to kind of improve the underlying inflammation and cause for their asthma, but how do you know when it's okay to stop?
So a lot of it, so similar to what we kind of talked about with outgrowth, it's when things are quiet, when things are, when you're kind of looking as you're sitting and talking with your primary care doctor or your asthma specialist, it's really important for doctors. If things have been good for one asthma guideline says 12 weeks. Some says every time we sit down, is that they say, hey, every time we sit down, we should be saying, hey, if things are good, should we consider stepping down? And so I would always make sure you're talking with the doctors that are helping to take care of us. So I don't think that we should ever stop without communicating, because I think that that could pose a risk. But I think that as long as you're having a good relationship with your doctor and saying, hey, things are good, is now the right time? And maybe it's not, right? Maybe it's your child's asthma's flared by illness and it's October, November. That may not be the right time. But if it's May and your child doesn't have allergies and their triggers are infection, that may be the right time to step down.
So meaning things are better. You're not having to use that albuterol rescue at
Yes, ma'am.
all? Yeah, that's great. Okay,
Or
good
outside
to
of
know.
exercise, things that like would make it so that we could function.
Gotcha. Okay, so exercise-induced asthma, now that you mentioned exercise, how would you approach that? One of your slides said something about possibly starting it before versus during exercise. How do you know when to time that?
So most of our medicines, whether that's albuterol or kind of that newer approach that talks about formoterol, which I say newer, but I mean, it's still about 18 years old. So it makes me, if that's new, I'm a spring chicken. Whenever we actually sit there and talk about uh, asthma in exercise, you want to be getting ahead of it so they can kind of get their lungs ready. So the way that I talk about it with my adolescents is that it's kind of like if you're straighting up to a race line and the timer goes off or the alert goes off, the gun goes off for them to start, is that their lungs are still napping back on the couch at home. And so what taking that albuterol or that formoterol containing inhaler helps get their lungs ready, gets them prepared. And so we usually time it around 15 to 20 minutes so it's peak in there, because most people have problems kind of as they're getting into exercise or kind of the middle of exercise when they're going to run into problems. And so you try to time it a little bit ahead, so about 15 minutes ahead, not right as you start, not like as we're running out onto the PE field, we're taking it, but kind of trying to get ahead about 15 minutes.
Okay, our next question is whether asthma is becoming more common, and if so, why could that be?
So that's yeah, I would say yes. I think part of it is that we're having better knowledge about when to consider things asthma. I think that that's one thing. I think that we are seeing a rise in a lot of chronic diseases. I think that we are seeing asthma a little bit more often right now. Some of it may be our ability to diagnose. Some of it may be our attention to those symptoms, and then some of it is probably our interaction with our environment. Some is probably more interaction with the inhalants that we're around or kind of the urbanization, because we do see it at higher rates in our urban communities rather than necessarily in our more rural or kind of farm life environments. Not that you can't have it, you can have an urban environment where you don't have asthma and you can have a rural environment where you do have asthma, but it's a little bit different rates depending on certain kind of exposures, and it probably is related more to what we're seeing and what we're breathing in.
Are there any non-medication therapies or home remedies that people can try to either treat or prevent asthma?
So there's been a huge emphasis on prevention. In some of the studies, they don't show huge show huge risk, but they also don't show huge benefits. So some of the things we've looked at, vitamin supplementation, vitamin D supplementation, especially in people who are lower in vitamin D, it wasn't amazing. It didn't revert everything, but it helped, and especially as we're all kind of staying inside a little bit more, it's something that we can always think about. I think that, I mean, going back to the basics, right? Getting active, exercising, keeping our weight down, because we know that if the lungs and the chest wall has to work harder because of weight, that can be hard. And some of the medicines we use, oral steroids, help make people gain weight. And so trying to make sure that we are enabling our kids to be active can also help control their asthma to begin with too.
Okay. And then the next question has to do with classifications of asthma. I've heard people say things like it's mild or it's moderate, intermittent, persistent. What do these
Mhm.
terms mean?
So some of these are medical terms. And so it's always important for us. So doctors, whenever we communicate, have to be able to communicate severity to each other. And so it's kind of like when we talk about it, we have different categorizations that kind of have been around for asthma from intermittent. So we only have, very infrequent times we have it, less than twice a month, and it's really not waking us up. And we have less than one exacerbation per year, or kind of one flare up per year. And so we kind of break it down into intermittent, mild persistent, moderate persistent, and severe persistent. Some of these are so that doctors can communicate and kind of give us warning flags. And I'm always cautious whenever I use the terms mild, because whenever I say mild as a healthcare professional, and I'm talking to Dr. Shu as a healthcare professional, we're using mild in different terms, because whenever we say mild, I don't want you to hear that I'm saying that your child's asthma is not important. I'm not trying to say that your child's asthma is something that we shouldn't focus on. That's how much medicine is it taking to control their breathing, and how much is it interfering with them? Because we know that when you look at pediatric hospitalization um, uh, data, people get hospitalized at the same rate for mild asthma as they do severe asthma. And so you can't just say, oh, I have mild asthma, therefore I'm fine. You really have to treat the individual more so than anything.
Thank you so much for taking that time to tell us all about asthma basics and answer our participants' questions. I'm going to turn things over back to the AAP now to wrap things up.
Great. Well, thank you so much, Dr. Shu and Dr. Dunn, for all that great information. We want to remind everyone that you can register on healthychildren.org for our e-newsletter, personalized homepage, and special offers. And don't forget, you can follow us on Instagram, Facebook, Threads, and Pinterest. Also, subscribe to our new Healthy Children podcast. Listen to it wherever you get your podcasts, or you can go to healthychildren.org podcast. And that's the same place you can find the archived recording of this webinar under tips and tools on our website, healthychildren.org. We hope you enjoyed today's webinar. You will be receiving a short survey from us soon. Please let us know what you found helpful and any suggestions you may have. Finally, we want to give a special thank you to Sanofi Regeneron for their support of this webinar today. Thanks again, everyone, for joining us.